Thank you everybody for coming today. For those of you who are in the room, could I ask you to make sure your devices are on silent? If you want to tweet, the hashtag today is Human Tech, and we're at Oxmartin School. And welcome to anybody who's watching live online. I'm delighted today to welcome Dr. Fred Hirsch and Dr. Gary Clifford to speak on how mobile phone technology, smartphones, can be used in healthcare, both in the developed and developing world. Dr. Hirsch is Clinical Research Fellow in Essential Healthcare at the George Institute here in Oxford, which is part of the Oxford-Martin School programmes. And he focuses there on the intersection of healthcare and technology, looking at how we can harness technologies to improve access to essential healthcare. Before working in academia, he was a medical doctor and had a career in the technology sector. And as part of that, he was co-founder of an NGO called MedTech Outreach Australia, an NGO working in telemedicine. He's also part of the NCD Free team, which uses tech and new media to raise awareness and action on preventable NCDs. Dr. Gary Clifford, who's joining us via Skype today, is Associate Professor for Bioinformatics and Biomedical Engineering. He's also the Director for Affordable Healthcare Technologies at Kellogg College and the Interim Director of Affordable Healthcare at the George Institute for Global Health. Prior to Oxford, Gary was a principal research scientist at MIT, where he developed a number of award-winning mHealth projects and research. So I'd like to welcome our speakers, and we'll start with Dr. Hirsch.
Thank you very much. It's a real pleasure to be here today at the Oxford-Martin School, talking about one of the grand challenges, really, of the 21st century, and an area that I myself, and I know Gary as well, are very passionate about, and that's healthcare, and how technology, in particular mobile phones and smart devices, provide an exciting opportunity for transforming the way we think and deliver care. So what is the problem? I suppose I wanted to start by saying something. You know, there have been a lot of improvements over the last 20 years or so, and when we look at the global burden of disease, we see on the left side 1990 and on the right side 2010. And if you look at the changing order of the ranks there, you've got some infectious diseases are dropping down, those are the blue, and in the red you've got some non-communicable diseases or NCDs that are moving up. And the trend in infectious disease rates falling is good. It's a good thing, particularly for infant under 5 mortality. It's not enough to meet the Millennium Development Goals, but the trend is definitely heading in the right direction. On the other hand, though, and partly due to our global success, if you like, and the globalisation of the common risk factors for non-communicable diseases, the burden from these is going up quite dramatically. And those are things like heart disease, as you can see, ischemic heart disease and stroke, and other conditions like diabetes, cancer and chronic lung diseases. And this is set to continue. So by 2030, the prediction is that infectious disease rates will be decreased by 7 million, and whilst NCDs will roughly double over that time. And this is really a truly global problem. So NCDs cause 63% of global deaths, and 80% of those occur in low middle income countries. And the major factors that have been attributed to this are smoking, poor diet, physical inactivity, and harmful use of alcohol. And it's in resource-poor settings, in developing economies, where NCDs kind of have the most impact, if you like. They affect younger populations, so you find the first age of a heart attack is much lower, 53. And 90% or 8 million NCD deaths actually occur before the age of 60. It's on a different scale to, I think, anything that we really can think of. So I just wanted to use this example of type 2 diabetes, and it's estimated currently there's over 350 million people living with type 2 diabetes. It's probably an underestimate. The latest figures from a study in JAMA, I believe, looking in China, suggest that 10%, or approximately 110 million people there, have type 2 diabetes. And I think what's incredible about this is that 1 in 2 people are unaware of the diagnosis. And it's, in fact, a largely preventable condition. So to phrase our global health challenge, I'd say, currently over half of the world lacks access to the basic medical care required to either prevent or manage these common conditions that will cause premature death or disability. And that the social and economic consequences of this are enormous. The World Economic Forum predicts something like $43 trillion loss in economic output as a result of NCDs, let alone the social costs of premature death. And it's not a lack of know-how. We have plenty of evidence, and we've spent the better part of decades generating guidelines for how do we best manage these conditions, how can we prevent these conditions, from all the way through from childhood illnesses in under 5s through to type 2 diabetes and heart disease. And the George Institute itself, in fact, has been, as a world-leading research institute, has contributed significantly to this evidence base. And the question is not a matter of how, or not a matter of lack of know-how, but how do we go and translate a lot of these interventions, which are some of the most cost-effective that we have at our disposal. So it's a problem of implementation. On the one hand, individuals there's a lack of knowledge, which comes from lack of access to information, lack of choices and health literacy, obviously education. Health systems, particularly in developing countries, are weak, and they lack the adequate financial and human resources. So there's a gap of over 2.5 million health workers globally, mainly in developing countries, where it's very common to have less than one doctor per 1,000 people. And health systems that are already struggling are very ill-equipped to deal with these new non-communicable diseases like heart disease and diabetes that require a different kind of response. They're chronic in nature. And there are lots of local barriers that need to be addressed. So the world has changed in other ways too, and this is the exciting thing. The spread of communications technology has been unprecedented in history. So today, 90% of the world is covered with at least basic mobile phone access. It's more people than have access to water and sanitation. And if you look particularly on the far right of the page, like the rate of this is so dramatic. It's faster than any other technology in history. And the coverage that people have currently allows them to make phone calls, send and receive text messages, but these networks are rapidly expanding to provide more support, more data, which basically provides access to the internet. And there's 4 billion people who currently aren't online. So this mobile phone revolution, if you like, has created new opportunities and new markets. You think about M-Pesa and mobile banking in sub-Saharan Africa. And for the first time in history, we can really start to think about bringing healthcare to people even in the most remote corners of the world. And that's really what we call mHealth. So mHealth is the use of mobile and wireless technologies to support the achievement of health. And it's a really broad field, and it makes it a little bit challenging because really any use of a mobile phone is, for anything related to health, is classified as mHealth. And over the last decade or so, there's been a proliferation of small projects or pilots, and mainly those have focused on how we can use initially kind of PDAs, but now simple mobile phones to do things like promoting behaviour change, so smoking cessation via text messaging, medication adherence for patients, particularly with chronic diseases or things like HIV, for supporting health workers, especially in the areas of child and maternal health care, avoiding drug stockouts, so thinking about some of those health system barriers, having available medications at the time they're needed, preventing the peddling of counterfeit medications, and improving data collection. And I'd say whilst the evidence base itself is still emerging, the debate around mHealth, I think, has shifted now from not if, but how. So I think it's an exciting time to be alive, actually. I think the world is changing at an unprecedented rate. And most of us here, rely on technology in ways that was really unimaginable a decade ago. I mean, I do in ways that was unimaginable 2 years ago. So we've had this convergence of, computers with connected devices, with mobility. And I think that's what these smart devices, smartphones and tablets, and even the new category called phablets, which is a phone that's a tablet, are allowing us to do. And I think that, you know, this is the dominant computing device of the future. I want to show you why. So if you think about how quickly mobile phone coverage and usage spread, the same thing is happening now for smartphones. So globally, it's predicted that by 2019, there'll be 5.6 billion smartphones. A lot of those connections will take place in developing economies where mobile telephony networks will have spread to be able to support 3G and other data speeds to allow them to access the internet and other things. And in fact, this year alone, in India, there's set to be over 400 million 400 million users of smart devices. That's more than America. There'll be over 1 billion Android devices, and you know, technology is getting faster, it's getting cheaper. Again, it's predicted that there'll be a $50 US dollar phone from China this year. This here is a phone that you can get for £50. So I think that there's the potential that developing countries, if you don't look too far ahead, looking ahead, sorry, but not too far, developing countries could leapfrog the PC era. And I think that there are amazing possibilities for health. So there are some things that are holding us back. There's been a lot of hype around mHealth. Maybe I'm contributing to it here, but I think there has been a lot of hype. It's suffering from what they call pilotitis, not really being able to break out of small-scale projects and other things. And I think some of that, you know, some of those questions are around recognising that mHealth is not a standalone solution. You know, it's really going to be, how does it fit into our daily lives, whether that be work or play, for doctors, for health workers, and for patients alike. And I think it's a question of design. So understanding, you know, what are the unmet needs that healthcare can help solve, and then moving towards solutions. So I wanted to tell you a little bit about a Smart Health program, which is a research and development program at the George Institute for Global Health that I work on, and it's around primary care. And SMART stands for Systematic Medical Assessment and Referral and Treatment. And it's a program that draws on our experience of translating some of this evidence into practice. And that's come out of our primary care group. And it's about affordable, technology-assisted, high-quality primary care systems. So the goal of the program is to really address the major causes of the global causes of ill health. We've started with cardiovascular disease. That's an area that we're very familiar with. So this is a big picture, and it's a bit of a schematic about our mHealth ecosystem, if you like, for primary care. And there's a few things that I wanted to emphasise. This is really about understanding how current and emerging technologies can work in an integrated fashion, if you like. And it very much focuses on addressing some of the human and system factors that are vital to this work. This is not just about the technology, but about seeing it within this ecosystem. And so the idea is, you know, quite simple. What we're doing is building out a suite of decision support tools that allow us to harmonise guidelines that are contextually relevant, so they're different for different places, and then build different mechanisms for delivery according to the use case. So they're complementary. So if you think about, there's a clinic scenario where you might be seeing a doctor or a health worker, but we also want a patient to be able to be supported by these, and we want a carer to potentially be supported. So the same kind of decision support can be delivered in different ways and on different types of technology. And one of the exciting things is how can we use this to equip health workers on the ground with the tools, so on a low-cost tablet device, together with diagnostics and sensors to be able to provide quality care. And that's what we're doing with a program in India that we've worked with Gary's group on. So this is the Andhra Pradesh Rural Health Initiative. So the George Institute has been working there for a number of years now. It has a number of primary healthcare centres which are supported by government and NGO-funded village-based healthcare workers. It's a population of over 200,000 people that have very limited access to qualified doctors, but there are lots of healthcare workers. And so what we've been doing here is working with an international collaboration of public health, medical, engineering, technology, some design, and we've built a clinical decision support tool that's focusing on cardiovascular disease. So this particular decision support tool is based on the WHO guidelines. That's what they would use in rural India. It's been built together with kind of involving people within the community. It's been translated into the local language. Obviously, the picture on the right doesn't demonstrate that. And really what we're doing is equipping community health workers or ushers who are effectively high school trained, maybe mainly women, who go out into the community and can then identify people at high risk of cardiovascular disease. And what we've found in the preliminary results of the pilot is that there's over 30% of people within this community are at high cardiovascular disease risk, which means that they could benefit from lifestyle modification or low-cost treatment that could prevent future ill health. And so the community health worker is out there with a tablet device, is able to perform this assessment. They're able to then act as a bridge. They can provide some communication. They can provide some education and advice to a patient, to the community. They can refer them into the clinic where a doctor using a similar type of device or system can then take the necessary steps. At the moment, a community health worker can't prescribe medications, for example. And then on the patient side, patients, if they have access to basic mobile phone, can sign up to receive support via SMS in terms of medication adherence and reminders to come back to the clinic. So this is a study that's going on. It's been funded by NH and MRC in Australia. We've completed a pilot phase and it's about to go into a large-scale trial that will involve 18 primary healthcare centres, 54 villages and over 10,000 people. So before I hand over to Gary, I just wanted to end on this note. I think that, I think there's really exciting opportunities for smartphones, for mobile phones, for technology, but technology is really only part of the solution. I think this is it's a design problem, it's a design question. And I think it's really vital that we work to understand the context, that we collaboratively explore ideas, brainstorming and iterating and developing prototypes, and then we work on developing the solutions that we can evaluate in the local context. Thank you. Ooh.
Fred, I'm not sure to take over, right?
Yeah, got it.
Can everybody see me okay? Okay, well, Fred, that was a wonderful survey of all of the issues, I think, around mHealth and the potential. What I wanted to do was just drill down a couple of specifics of the technology and talk about what some of the issues are, some of the potentials and some of the pitfalls as well, and what the future landscape might be around mHealth and particularly the use of smartphones. So if I can get the slides to advance. There we go. So I think you can talk about what the potential is in terms in a nice soundbite, which we could call smartphones, thumb sensors, and big data. So the essential key is that we have these incredibly powerful smartphones that are ubiquitous and increasingly so. And they contain within them a series of sensors, as Fred has pointed out, but also they have the potential for very simple sensors, very low-cost sensors to be plugged into them, either directly through USB ports or wirelessly through Bluetooth or other wireless modes. And so we have this potential to be able to hook in these peripheral devices into the smartphones and collect an enormous amount of data, what people are calling big data, for want of a better term. And so we're going to be able to collect masses of data from individuals that we then need to know how to process. What I'm showing here are three brief examples that I'm going to talk about. The top one is a blood pressure device, which a group of my students here have built. In the bottom right-hand corner, we have a very MacGyver-like digital stethoscope, and in the bottom left, we have what we call smart pumps, and this is a collaboration with Geography, and is looking at ways of providing monitoring of clean water. So let me talk about the design aspects of a very, very simple peripheral device that can turn a smartphone into an intelligent diagnostic instrument. So this little device here that you can see in the center has, I don't know if you can see my cursor over this, but there's, in the central picture, you can see a tiny little sensor that is picking up just pressure. So on the previous slide, I showed that this was plugged into a standard blood pressure cuff that a doctor uses in everyday scenarios. And on the other end, there's a USB port that allows you to plug it directly into the phone. And then all we've done is stuck it in a tic-tac box as a temporary low-cost solution to an enclosure. So this device has a $1 blood pressure sensor in it, or a pressure sensor. And the cuff that it plugs into, this standard cuff, turns out to cost $1 to $2 itself. So now we have a $2, $3, $4 device, depending on how much your manufacturing costs are. It doesn't require any power because it draws that parasitically directly from the phone, and it can upload information directly into the phone, which can then pass into the cloud and straight onto a healthcare worker. So there's no information loss, there's no transcription, there's no transcription errors, and the data is just passed cleanly through in a store and forward manner into a back-end database. The phone itself does all the blood pressure calculations, checks the quality of the signal, and then feeds back the information to the user. And this is the key, I think. Not only is the device extremely low cost and essentially disposable and can be supplied with the phone, so you're dealing with supply chain issues, but it can also intelligently interact with the user to tell the user whether they're using it correctly. And this can be in a very complex way and can involve videos, images, and using the sensors on the phone decide what the posture of the patient is, what the movement of the patient is, and whether the quality of the signal is acceptable for diagnostic purposes. So this is the key, I think, that we have this new paradigm where we're able to interact with the caregiver and the patient in real time and feed back information to them about the use of the device, and then upload the data directly into a database, which then pings the medical healthcare professionals and refers them on for further treatment, or provides an assessment and a diagnosis or a prescription there and then. Second example I wanted to show you is something perhaps even more simple. This is one of the first projects that we started at MIT, and then David Springer and Tom Brennan continue to develop out to this day at the Institute of Biomedical Engineering in Oxford. And this is basically a digital stethoscope. So if you look on the app market, you'll see plenty of digital stethoscopes, but essentially they're voice recorders. The difference here is that this digital stethoscope has a processing system within it that allows us to actually analyze the data and give a reading. It consists of basically the hands-free kit that comes with the phone, together with an egg cup. So what you can see in the top right there is an egg cup with a hole drilled out of the back of it. And then the microphone of the hands-free kit is just blue-tacked into the hole. So this is your stethoscope. And by plugging it into the phone, we have an incredibly powerful audio signal processing unit within the phone that we often use for voice analysis or voice encoding. And we're using that to process the data and pull out useful indicators about cardiac activity. One of the key things again here is that the phone checks the quality of the recording as well as analyzing the rhythm. So if you look at the interface on the bottom right-hand corner, what you see is across the bottom 5 stars, and then 2.5 of them are filled in green. What that's telling you is that the signal quality of this particular recording that it's making at this point in time is not particularly high, and that the user might want to reposition the stethoscope to produce a better recording. At the same time, they can be listening to the recording and actually deducing for themselves whether they can hear the heart beating. The other thing it does at the end of the recording is produce a recording that the user can play back, and also a diagnosis of the rhythm. Again, all of the data is uploaded to a back-end database, so the user never loses any data, and they associate this directly with the patient they're recording the data from, and then a referral can be made almost immediately. At the moment, we're trialing this in South Africa and looking at rheumatic heart disease in children, and we're hoping to have some clinical results from that later in the year. The third project I wanted to tell you about is smart water for development. So this is a collaboration with geography, with Patrick Thompson and Rob Hope there, who lead the Smart Water project. And what our engineers at the Institute of Biomedical Engineering have done is provide some mobile phone technology to help the monitoring situation. So the key here is that 1 in 3 hand pumps in Africa are non-functioning. The fault can take weeks to be reported, and the systems of maintenance are highly variable and quite inefficient. So there can be a lack of safe drinking water for a significant period of time, and this has large health and economic downstream impacts. And often the effect is irreversible, especially if this occurs to young children. So we're all fairly familiar with the idea of provision of clean water being essential, but the key here is that you can provide a pump to allow communities to access the clean water, and that's the kind of pump that you see in the bottom right-hand corner. And even though it's incredibly robust, the fact is it's being pumped thousands of times a day, so obviously it has mechanical failures. So the key is, how do we notice this either early or even before the actual failure occurs? So our solution was to place the guts of a mobile phone within the handle of the pump itself. So what you can see here is, in the bottom right-hand corner is a picture of Patrick testing the innards of this pump handle and installing this. It's basically a GPRS unit with an accelerometer built into it. So just really the guts of a mobile phone completely stripped down. And what happens is, as you pump the pump, it records accelerometry or movement in the pump handle, and then that leads to a calculation of how much the pump handle has been pumped, and then an hourly text message sends out a calibrated amount of water that has been pumped out of the well. One of the key issues is if it stops getting pumped, or it's being pumped almost at random, that means that there's probably a fault going on in the pump handle, and people are not accessing clean water from the pump anymore. So what happens is that we're able to monitor that in real time and report faults extremely quickly and send out somebody to repair the unit. In fact, by doing this, we can even hope to predict when these failures are going to occur, because obviously mechanical failures are preceded by sometimes a rapid, sometimes a slow mechanical failure. So what we'll see is increased juddering in the handle that we can pick up from the accelerometer, and then we can translate that into a warning to tell somebody to proactively go out and maintain the pump. It also allows for objective data for monitoring and regulatory oversight by the governments and donors, and allows for better targeted future investment, so we can work out what areas the pumps are being used in and what areas where there is actually no need for the pump. So it increases our ability to survey. And a very key element to this is that we also have a sustainability model based on insurance. So essentially what happens is you pay a small monthly amount to have this monitoring system placed in your water pump, and then what that buys you is the insurance so that somebody will come out and maintain it and keep the water pump going and ensure that you have a continual supply of safe, clean drinking water. Okay, so I also wanted to talk a little bit about the risks of mHealth. I think one of the key issues is that we have the danger of a lot of wheel reinvention. So what I mean by that is there's this danger that we could be developing yet another version of expensive Western healthcare where we require many experts to read the data. If you think about it, if we're trying to provide healthcare to billions of people who currently don't have access, and yet the patient to doctor ratio is as high as 20,000 or even 50,000 to 1 in parts of Africa, then there's no way that we can sustainably and scalably build a healthcare system that's predicated on the idea that there's a doctor on the back end reading every single piece of data that comes in. So there needs to be a reinvention essentially of the healthcare system. We also need to think about sustainability. What kind of business model is going to allow us to deliver effective healthcare? Again, the models that we have in the West are models that are leading to increasing percentages of our GDP being devoted to healthcare. And we have this increasing desire to spend more and more money on more and more tests, more and more interventions, and more technology. And what we need to be thinking about is how do we actually use the technology in an efficacious manner. There are obviously privacy issues. Many people are very worried about the idea of somebody monitoring us, particularly for sensitive conditions. People are worried about big databases being stolen and sold to drug companies. And so privacy is a key issue, but also there's the potential for high security as well. And also people are worried about targeting at-risk groups. So for example, if you can identify an entire village that has a high prevalence of AIDS, is that going to make them a target for other neighboring people to avoid them or disadvantage them in some sense? And these are all significant risks. We also have the issue of compliance and longevity. So it's easy to become wary of using new technology. There's plenty of examples out there of how technology seems to have a very positive effect in the first 6 months, and then people become very wary of using this technology. So we need to think very carefully about the incentives so that we don't end up having a lot of white elephants that essentially are expensive and pretty useless to the communities. We also need to think about the regulation, whether we over-regulate or under-regulate. Under-regulation is obviously a worry in terms of malicious or non-validated apps, but we also have to think carefully about whether we over-regulate and we put up artificial barriers that increase the costs of providing mHealth into the indigent communities or the communities with low resources. Another key issue is the heterogeneity of the platforms and the devices. So we have many different systems that have many different sensors on them, and these can have different biases and variances. So you have to be very careful if you're talking about using and developing an app and realizing that the actual sensor hardware within the phone isn't very homogeneous, and this heterogeneity of different sensors can lead to large differences in the accuracy of any particular algorithm. And so thinking about how to deal with that is going to be extremely important. And there's also the issue of overdiagnosis. At the moment, the Western healthcare system is tuned to be overly sensitive and under-specific. We're very worried about missing a particular event. We're worried about missing diagnosing anybody. So what we do is we tune our algorithms to be overly sensitive, and then we hope that an expert on the back end is going to review this and will tell us whether there is actually a reason to continue the referral and whether it's actually a true positive or a false positive. So unfortunately, as I've already said, with billions of people trying to access healthcare and only with a very high patient-to-doctor ratio, that kind of paradigm is just simply going to overwhelm the healthcare system. Even if you have a 99% accurate diagnostic, if you're performing that every day and you're performing 10 other different diagnostics every day or every week or even every year on 4 or 6 billion people who currently don't have access to healthcare, then you're going to totally swamp the healthcare system. One of the key issues, I think, at the moment is scientific validation of the apps. So currently there's a flood of random apps. In the top right, you can see that's actually how I slept in November. So that's an app that tells me whether I was in deep or light sleep. So the deep is the big blue bar and the light blue is the light sleep. And that's purportedly telling me how well I slept and how much I oscillate light and deep and light sleep. Unfortunately, there's no publication that actually tells me how accurate that is, and I'm just expected to accept that on face value. And also, I'm meant to diagnose for myself whether that means something good or something bad about my health. So these are two key issues. There's a lack of scientific validation, and then there's a lack of follow-up or interpretation to turn this into something that's actually useful. Sleep monitoring is a prime example of this. There's in fact hundreds of apps out there, and none of them actually provide scientifically grounded sleep quality estimates. We published an article on this quite recently, and I'd encourage you to have a look at it if you're interested in the landscape of apps that are out, mHealth apps that are available out there. You can see just the kind of heterogeneity of apps and what they're purporting to say, but actually how little scientific evidence is behind these. In fact, we surveyed over 60 apps on the market, and we found that not one of them had any scientific grounding for the readings that they were feeding back to the user. What we have done in the last few years is try and address that issue by providing and developing a validated series of apps. And this is another example of one of them. This is actually a sleep apnea detector, and it tells you your probability of having a risk of sleep apnea. So obstructive sleep apnea, or OSA, is when your respiration periodically ceases during the night because your airway is collapsing around your esophagus and preventing you from breathing. And then the lack of oxygen and the buildup of carbon dioxide wakes your brain up. And this cycles for every 2 or 3 minutes during the night and prevents you from having restful sleep. And has a lot of downstream effects, from traffic accidents to cardiovascular disease. Yet the screening for this is quite expensive and requires a series of referrals. What we've done is developed an app on the phone that allows you to, it analyzes the movement of your body as well as the snoring, and optionally also the oxygen saturation in your bloodstream, and then comes out using a machine learning algorithm of whether you're at risk of obstructive sleep apnea, and then allows you to be referred downstream. And the key behind this is that we validated this using a database of around about 1,000 patients collected at one of the local sleep clinics in Oxford. It has 92% accuracy, 100% specificity, and 87% sensitivity. And you notice that this is one of the key issues. We've actually tuned this to be extremely specific, but not extremely sensitive. Sensitivity is pretty good. But the key here is that we're not referring people if we're not absolutely 100% sure that they've got sleep apnea. I should note that this isn't CE marked or FDA approved, so it's not available for usage right now. So the regulatory issues around this are pretty interesting, but it's going to be exciting to see how we develop this and how we get it onto the market. So I just want to finish by saying that there are some big opportunities out there. Linking back to what Gary Kasparov said last term, there's enormous opportunity for humans and machines to work together. And as Fred was saying, the key exciting thing here is that we're leapfrogging, in many countries, leapfrogging personal computers. And the PC is really the actual mobile phone. And it's your pocket PC that's allowing you to interact with your own data. And what's going to happen, I think, is that the apps are going to teach people how to do diagnosis and how to look after their health. And also the user, as they gain more knowledge, is going to teach the app when it's right and when it's wrong and what knowledge it's missing. And then that's going to be absorbed into the app, uploaded to a cloud database, and the app's going to learn and evolve at the same time. So what we're having is this interaction between humans and machines so that we're able to provide medical diagnostics to the consumer or to the patient. But the patient and consumer are also going to provide information that helps improve the device in almost real time. So we're going to have a learning healthcare system, I think, mediated through mobile phones. You're going to have a portable healthcare record for continuity of care. So you're going to be carrying around not necessarily the information on your phone, but at least a plug to a healthcare record in a cloud that allows you to be able to show your healthcare record to any provider whenever you need to. And this longitudinal medical record is going to be yours to do what you want with. It's going to allow rapid information transfer for diagnostics, referral, and follow-up, even for the poorest and most remote people. And I think because of this, the opportunities far outweigh the risks. We've got a wonderful and exciting time here to reimagine global healthcare and potentially provide access to almost everybody on the planet. And I think that's the big opportunity and the big excitement here. I'm just going to finish by quickly throwing up the slide to thank all the funders, because of course this couldn't be possible. This kind of work isn't possible without people generously giving us money to do this kind of work around the world. And I'm going to finish there. Thank you.
Okay, so we have plenty of time for questions today. What I'd like to do is just get a feel for who in the room wants to ask a question, and then I can direct Clara to the first couple. We've got two at the front, Clara.
Hi there. Just a question about the stethoscope. Now, previously the data from that stethoscope would have just gone into a doctor's ears and then be lost. But of course, you're now recording that data and then sending that data up to the cloud from hundreds and possibly thousands of people. You mentioned about the data sensitivities around that, but that does seem to be a very interesting database for possible future medical research. Is that a possibility?
I'm sorry, could somebody repeat the question, please? I'm having trouble hearing it because of the echo.
Yeah, so Gary, the question was basically around the digital stethoscope, collecting lots of heartbeats and heart sounds and then syncing that to the cloud. What's the potential from a big data perspective?
I think the potential is enormous. If you look at some of the databases that are out there at the moment, the public databases that is, and perhaps even the private ones, they're fairly limited in scope. Even though they're incredibly wonderful resources like physionet.org, if you look at this, they have hundreds, even thousands of patients in some databases. But what we're finding is that even though these were laboriously collected by hand and annotated by hand, and they're incredible resources that have led to wonderful developments. What we're finding nowadays with big learning algorithms, with machine learning algorithms on big data, is that the heterogeneity of patients and diseases is leading to the need to expand these databases enormously. And if we have an ability to capture this information across the planet through mobile phones and upload it to databases where we can assemble enormous databases, then I think it's likely to lead to a watershed moment in our ability to process these data and provide incredible diagnostics. I think our limitation at the moment is just really the volume of the labeled data that we can get hold of. And labeling is a key issue as well that I can talk about.
I was wondering if you've given consideration to using things like the mobile blood pressure to help with clinical trials, both to try and detect adverse events and also increase the number of data points that can be captured.
So, do you mean specifically the adverse events around what? Kind of. Sorry.
I'm thinking maybe in a phase 1 trial where you'd be doing lots of monitoring of blood pressure to check that there are no adverse events and the drug's not having any untoward interactions, and then later on you may send the patient home and only getting them back in once a week to check. Maybe with this you could be doing more frequent checking, which could give you information on adverse events but also give you better data about the effectiveness of the drug.
Yeah, right. So Gary, it's another question about I suppose the opportunity for using remote blood pressure monitoring potentially in clinical trials, phase 1 clinical trials for pharmaceuticals and others, where you're trying to pick up adverse events earlier on. Has there been any use of that? Are there any plans? What do you think the opportunities are?
Yeah, I think the opportunity for these kind of devices is not so much in the area of things like clinical trials, unless you're doing something enormous and in very remote regions like the Smart Health project that we have in southern India. I think the exciting thing around something like this is that you have the ability to provide the diagnostic capability to people in very remote regions and with very few resources, so outside of the clinical trial umbrella really, and yet allow them to be able to see the changes in their blood pressure over time, because except in very extreme cases, it's the slow change in your blood pressure from month to month, year to year, that's going to be more the worrying thing than actually a one-off reading. And so enabling people to be able to sample themselves more frequently, I think, is going to be a key benefit. I don't know if you want to talk to this as well, Fred.
Yeah, I mean, I was just going to say, I think that, I think we sometimes take for granted the skill, if you like, that's required in taking blood pressure and things, things that seem very, very simple. And yes, there's lots of, electronic devices that run into all sorts of problems with calibration and other things. But I think that the opportunity is in that the accuracy, the potential accuracy of a very simple device that's going straight into a mobile phone, that's effectively plugged into a patient's electronic health record. All of these things are very much kind of emerging as real possibilities. And I think for resource poor settings, it can reduce a lot of that variability within a clinic setting. Yeah.
Anybody else got a question? Yeah, the lady in the middle.
Thank you for the presentation. I had a question on regulation in mHealth. Are there any steps towards people who create non-scientific apps that would have negative impacts on health and in the developed or low and middle income countries?
Yeah, absolutely. So, I mean, there's a big, sorry, I'll just repeat the question, around regulation, Gary, for apps and for non-scientific people creating potentially medical or health-related apps. I mean, I think this touches on one of the big kind of problems that we have at the moment, which is to take a term, in the midst of an epidemic, to some extent. And when you look at health and wellness apps alone, there's something like almost 100,000 between, the Apple Store and Google Play, and most of them are useless. They're not based on any kind of any evidence base. They can make whatever claims they want, really. And I think that is a big challenge. How do we sift through all the noise in order to find the signal when it comes to these types of things? So I think that there's a big role for evidence-based apps. The FDA in America has started to do things around apps that are effectively medical devices, and so they need to go through a process there. But Gary, you might be able to comment a little bit further, but I think it's a really important question and a really important issue.
Yeah, I think it's one of the most important issues, because clearly there has to be some type of regulation, because you just don't want all of these apps on the market being used in a diagnostic fashion. And I think it's naive to believe people don't use them. The disclaimer on it is always, this is not for medical purposes, but if you have no access to resources and yet you can download an app and use it, even though it's not accredited in any sense, but you perceive that there's some use of it, then you're going to use it. I think that's clear. So I think there's a moral imperative that we have to create scientifically validated apps. There's no question about that. And I think what worries for me is that if we put up large regulatory barriers, then we're going to slow down our ability to develop these apps, and we're going to actually lead to them pricing themselves out of the market for most people. So as soon as you build in enormous regulatory barriers, you have a serious problem in many developing countries, because now it's going to cost you $5 or $10 to download this app, and so you're not going to download it. You're going to download the free one that isn't regulated, and that's a big issue. And of course, in the Android market, which is by far the most dominant one on the planet, you don't need to actually go into Google Play and download the APK. You can download the software for it from any website, and it's very, very easy to install. Anybody can just click on it and install it. You just have to click one setting on your phone to allow it. So I think what we actually need to do is set up a website that allows people to post code and for the scientific community to comment on the validity of it. And I think that would allow us to accelerate our ability to push apps and devices through regulatory approval in developing countries much more quickly and at a lower cost, and could also help us work with developing countries to define what the regulatory procedures should be through that kind of website. And I think places like the Georgia Institute, Oxford University, MIT with PhysioNet, these kind of places can be the focal points for this kind of peer review as well. So I think it's going to be very much like we've done with scientific evidence in paper form. We're going to take this into an app form, and we're going to have an international debate about what does work and what doesn't work, and what the scientific merits and dangers are of each app. That's what I'm hoping, rather than a closed regulatory approach to the governance of these kind of developments, just because of the cost issues involved.
I just want to add to that. I think that certainly from our perspective, when we look at the opportunities in this area and how we can bring to bear some of that research rigor that comes around it, and also if you like, it's kind of inbuilt within the way that we think that it needs to be scientifically validated, that we need to ensure that when we build these decision support tools, for example, that are just at the core of maybe an app that's being distributed for some purpose, that's been validated, that it's gone through that process, that we can be sure that and at back end, I think also, Gary, touching on the question before, with all of these apps and as they come out, there's an even greater opportunity from this big data perspective, and to, as you say, kind of to be seeing the opportunity to fine tune and refine the offerings that are out there.
Yeah, I think so.
Hi. Hello. Hi. I'm particularly, thanks for the fantastic lecture. I'm particularly interested about the sustainability of mobile health, especially with the project which you're running in Andhra Pradesh.
Yeah.
To me, it's an excellent piece of work. But as Gary pointed out, how far, running a pilot or running an RCT is good, but how far it's integrated with the local healthcare system?
Yeah.
And because we have seen in the past that vertically delivered programs which are funded by international donor agencies, they perform well until the funding lasts.
Mm-hmm.
And once it's taken off, then, people have asked questions about such kind of programs.
Mm.
So I would like to know, especially the case, the example which you provided about Andhra Pradesh, how far you have managed to take on board the local partners, the healthcare system.
Yep. So it's an excellent question, and I think it really, it's part of it's a vital aspect to even thinking about doing this kind of work. Is that I think on the one hand, working within the context of the current system, understanding what those barriers and opportunities are, so not introducing potentially a totally fictitious environment, but also working with local health authorities, local health leaders, wherever they are. And that's very much part of what we're doing within this project in Andhra Pradesh. So the George Institute has a local presence within India and has for I think coming on 10 years now. We've worked very closely within that community for a long time, and within the local healthcare authorities who are very aware and supportive and understand, and are also interested in seeing how this might work so that it can potentially be scaled beyond just a research project. So I think that's one aspect of what we're doing there. I think more broadly, we're also trying to think and understand and develop an appreciation for what some of the other models of healthcare are within and around that area. So healthcare is provided by lots of different players, and also thinking about how could we develop these tools such that they might have wider use and application outside of a research project.
Fred, it was hard to hear on this end, but I think it was a question about sustainability.
Yeah, it was about sustainability and engaging with local partners in projects like the one in India, to ensure that we don't contribute, contagion to pilotitis.
Yeah, can I add to that? I think that clearly engaging the local community is absolutely key to the success of this, and they have to be co-developers and co-owners of the technology and of the entire system. I think they have to, in the end, take ownership of it, but I think that can only really happen if the ownership occurs at the start as you're building the project, so that everybody's bought into it. And then in terms of the sustainability model, I think that it's going to be, it has to be around a service delivery platform. I think the traditional, certainly from the point of view of medical devices, the traditional viewpoint of let's make a device, get it through regulatory approval, look at our profit margins and what we want to get back on the device, and then sell it and hope that people can use it to provide the information that they need. It's pretty much a dead industry in terms of global health. I'm talking about access to millions. I think we have to look more at the mobile phone industry and say, okay, it's a loss leader. We give away the hardware technology, and it's what added value we can provide as a service on top of that that will keep the consumer and the patient paying money into a system to allow you to keep it functioning. So it's going to be either a low-cost insurance model or a pay-per-use service delivery model, I think. Although I'm no economist, so there's probably plenty of people with better ideas on sustainability models.
Hi there, I'm Terence Eden from Telefonica. How can the open source community help you with this? I mean, you've already mentioned about scientific validity, you know, being able to check that these things do what they say they do, but then you also mentioned security. You know, you can't have confidential medical records either stored on a device unless they're secure or transmitted over the internet unless they're secure. So at the moment, is there anywhere where we can sort of go and help you, or is this waiting to be done?
Yeah, I mean, Gary, that's the question was around open source. How can the open source community contribute to this kind of work? You know, thinking about things like security of medical records, transmission of data, and others. I know you've been very involved in that, so do you want to field that
Sure.
one?
I forgot to mention when I talked about the regulatory issues, I think that open sourcing the code is pretty much the only way that I'm going to believe that the system says what it does on the package. I think the peer review through open source posting of code is going to accelerate the development and allow us to find and fix bugs faster. Because essentially, there isn't going to be, with low cost margins on these type of apps, I don't think we're going to be able to follow the same kind of structure that we do in the traditional medical device industry. And so this is going to have to be more along the model of the open source community, where people can still make money out of this through added value, but I think the core has to essentially be open source, so it's open to inspection. So I think the open source community's not only got the potential to contribute, I think they're going to be fundamental to the development of this ecosystem. And I think they have to be involved. I think we need to harness them. And we try and do that periodically through competitions, but I think that that the development of these kind of apps is going to be largely dependent on people contributing to the open source bases that are occurring. And that's particularly true, that's pertinent to the concept of security and patient medical records, not only because we want to keep them secure, but because we need to have standardization in terms of formats and data exchange if we're going to have longitudinal medical records and we're going to do big data analysis. So the schemas that these data are stored in is absolutely vital, and using open source medical record systems that everybody agrees on, such as OpenMRS, I think are absolutely key to the success of mHealth.
I'll just add to that. I think, I think that there's a lot of really exciting opportunities for open source. One of the things that I was thinking about when preparing this talk was, the democratization of software, and software development that's taken place, and you look at, how, as Mark Andreessen said to some extent, software is eating the world. And there's phenomenal opportunities for new industries that are kind of coming up as a result of, clever startups in Silicon Valley and other places. And, whilst that's not necessarily open source, it's all pretty much built on open source technologies for the most part. And, you look at from Silicon Valley to the Silicon Savannah, there is this interest in coding and development that, means that local innovators, can be developing local solutions that might be based on some, validated decision support tool, algorithm or something, but that, they can be solving that problem on the ground, working with people. So I think that's where, there's some really exciting opportunities here to engage.
Yeah, I think, Fred, sorry, just to add to that quickly, I think that's a very important point. I can't tell you the number of times that I've gone to low and middle income countries and been sitting next to somebody on a bus or a plane who's implementing a medical record system for a hospital or designing a piece of technology and are not aware that somebody has already posted an open source version of it and that they're essentially reinventing the wheel. And this siloed data approach, siloed coding approach, I think has to go by the wayside, and we have to work together because it's a group of fairly geographically disparate programmers working in low resource groups. And so we have to get together and engage the open source community to do this.
Okay, does anybody else have another question? I thought I saw a hand before. Oh, in the middle.
Thank you. The question which I had was just with regards to the funding of mobile health. Currently, my understanding is that a lot of the funding is coming from venture capitalist funds and the pharmaceutical industry. I just had a couple of questions. Firstly, how engaged are these sectors in deploying these technologies in low and middle income countries? Mm-hmm. And then secondly, your thoughts on some of the conflicts of interest that might arise as a result of that input of funds.
So Gary, the question is around funding for mHealth at the moment. Currently it's venture capitalists and pharmaceutical companies. What are the thoughts on that within low middle income country settings? Like, is there interest, and is there any conflict of interest, from pharmaceutical companies? So I might have a stab at that first. I think, you're right around. There's a big interest. Especially in America, around mHealth as the saviour. They call it the $1 trillion cure, and there's lots of venture capitalists and others, and also private HMOs and others are kind of pouring into this space, looking for that disruptive innovation, if you like. I think interestingly in resource poor settings, it's probably a bit different, but there is, Israel, for example, is actually funding a lot of tech startups, and they're looking very much now towards some of these emerging markets that are closer to their markets as places where their innovators can work. There's some interesting programs coming out of Ghana, so there is interest beyond just the developed markets. I think, though, also there's a lot of social impact investors, so people who are maybe not thinking about this from the commercial return on investment, but rather the impact that it can potentially have down the line, who are funding. And I think here you've got the Skoll Foundation, Skoll Centre for Social Entrepreneurship here at Oxford, is very interested in the healthcare space, and it funds a whole bunch of different healthcare entrepreneurs, some of which operate in this mHealth space. And that's a growing kind of market opportunity. I think it's something like $1 trillion, like under social impact investment that's kind of floating around the world, and that's only set to grow more. So I think the market does fail to some extent in healthcare. It's not going to necessarily be like it is in America, where there's a much bigger prize in terms of dollars. And so I think we're going to look for these other sources of funding. I'm not sure about the pharmaceutical funding of a lot of this, or the necessary kind of conflict of interest, but I think that there would need to be transparency, where that was the case. But I do know, I met recently a fascinating guy from Ghana who's building a pharmacy, kind of ecosystem, if you like, a mobile health system. And they work with a lot of big pharmaceutical companies because it's about how do they improve their supply chain and how do they improve getting their medications into local pharmacies and other things. And so I think so long as it's transparent and there's an understanding of the relationship, I don't see a problem with that. Gary?
Yeah, I couldn't agree more. I think there's obviously always a conflict of interest in your mind when you're talking about providing healthcare and talking about profit motives. But I think that we have to be practical and realize that humans are not ubiquitously or completely altruistic, and that we do need to make money in order to get on with our day-to-day lives. So thinking about what the business model behind that is very, very important. In terms of large pharmaceuticals, I've actually been very surprised about every pharmaceutical company I've talked to is extremely sensitive about all the bad press that they had, or some of the companies had, in terms of clinical trials in Africa that many of you might be familiar with. And so they're very keen to not be accused again of experimenting on people, or I've got to watch what I say here, I don't want to get sued. But they want to make sure that they're being seen in the right light. So I get the impression that they're keen to make sure that the information is used correctly, and their key concerns from the pharmaceutical industry, I think, are to do with counterfeit drugs and people really taking advantage of the free supplies as well. So there are lots of, if you spend time in developing countries, you'll see that often the doctor you go to gives you a sachet, which is basically a test strip or a freebie that they got from the pharmaceutical rep, and yet they're selling it to you. And that's undercutting their business. And what they're interested in is not so much squeezing more money out of it, but just making sure that supplies go in the right direction. So a supply infrastructure monitoring system, I think, is very important. From the patient side, I think it's having a full record of what kind of drugs are being prescribed to you and whether they're appropriate. So there's been some great work on that. If you look at Professor Koo at the Liverpool School of Hygiene and Tropical Medicine, he's done some wonderful work on making a public drug-drug interaction database for HIV medications. And in fact, we ended up working with him a couple of years ago, developing an Android app that would interface with that, allow users to be able to know whether the drugs that they're being prescribing are contraindicated based upon the current medications that they're on. And that kind of public resource, I think, is going to be essential. And it's something that, obviously we're going to have to pay for to develop. But there has to be a transparent business model behind that, I think. And I think the pharmaceutical companies will see that as being something that they want to do.
Do we have any more questions? We've probably got time for both, but let's start with this lady here.
Hi, just a quick question. I would have thought in some of these third world countries, the 3G coverage or the Wi-Fi access will be quite limited. So how are you sort of uploading the data into the cloud?
Yeah. So the question, Gary, was around data networks, cellular data networks in places like where we're working in India, limited access to 3G. So how do we upload the data to the cloud? But I'll just quickly say, so the project in India, which I think Gary's going to echo, is that I should have mentioned a little bit more maybe about that, but it doesn't have to be in a connected environment. So it works on, on 2G or GPRS type signals, and people can be offline, and then the data will kind of naturally trickle back up over cellular data networks when there is a signal. Okay, so that's not uncommon. So you don't need 3G. These are not. This is not like internet. It's not necessary a prerequisite that there's 3G access in these places. That we're not using kind of the internet so much, but you can still move data. And I'll let Gary explain a bit more around the technical side of that.
Yeah, Fred. I think you made the point very nicely. The concept of the way that we build these apps is a store and forward. So you have a very powerful device that pretty much has a cache of all of the relevant medical information and identities of the patients, and algorithms built into it because it's very powerful to allow you to do diagnostics locally. And then when you have a connection, you can add additional value on top of that and exchange and synchronize the data that helps you continue the diagnosis. We also use SMS on top of the 2G and 3G data networks for information exchange, because sometimes you don't need to upload a large amount of data. And you can often transmit the information that you want, which would be, in the case of the Smart Health project, cholesterol, blood pressure, a history, family history, and a couple of other minor data packets. And this can be transmitted via SMS if you need to. So the lack of connectivity is not an issue at all. There are issues around synchronization, but we've largely solved that.
Yeah, I'll just before we take the last question, so I mean, just to comment, you know, in that schematic, the idea is that, you know, you could imagine different types of devices connecting in different ways. And I should have pointed out a bit more that, particularly the project in India, that's a local application running on a Android tablet. So it's a locally packaged app. Whereas in other scenarios, you know, you might have another version or another app that might be running that is requiring, you know, 3G or cloud or, you know, kind of internet connectivity, but it's not, you know, that's the whole idea of imagining that you can use different devices according to the context and according to, you know, a user preference.
I have a question about data privacy. I was wondering, in particular in the project in India, to what extent are the patients aware that their data is being saved in this cloud database and the implications of that? How do you ensure that they're giving informed consent? And also, is there any mechanism for them to opt out of having their data stored permanently after it's been used for diagnostic?
That's a good question, and it's an important question. Gary, the question was about data privacy, particularly in the project in India. So are people kind of aware that their data is being stored somewhere, and are they able to opt out? So for in that particular project, I mean, the short answer is yes. You know, the health workers would go through a process of informed consent. People don't need to, you know, aren't obligated to participate. And in terms of, you know, if they should want to have their data destroyed, yes. So it's not kind of currently, in that model, we're not storing the data in the cloud at this stage. It's kind of stored in a secure facility. It's not publicly accessible. There's no patient-facing kind of view of that data in that particular project, so it's very much, yeah. Do you have anything to add?
Yeah, I think this is a really important in that the current medical record systems in most countries, which are paper-based, don't allow you that kind of facility. When data is taken, it's collected, it's placed in a paper record, and it's stored somewhere. And your ability to know who's accessing it, why, when they accessed it, what they did with that information, and whether you can control access to that is completely lost in a paper-based system. And what you have with a healthcare system that's mediated through your mobile phone is the ability for the patient to know exactly when someone's entering information into their medical record system and who that person is and when somebody even looks at that data. So I think there's an enormous advantage there. Obviously, we're not doing that at the moment in this clinical trial because that's something that would add another element of another dynamic into the clinical trial. But as Fred said, the patients have the right to opt out and or have their data deleted out of the system, which they never did with a paper record system in the past.
Great, well that's about all we've got time for. Before we thank our two speakers today, could I just draw your attention to a couple of the events we've got coming up in the next few weeks. On the 15th of February, which is a Saturday, we're teaming up with an undergraduate team to have a day of debates over in the Sheldonian. And I really would urge you to sign up for that. We've got some fantastic external speakers like Jane Cocking, who's Humanitarian Director of Oxfam, Mark Dybel, who heads up the Global Fund to Fight AIDS. So the details are on our website, do have a look. We also have Kumi Naidu, who's Executive Director of Greenpeace, coming on the 24th of Feb. And then on the 6th of March, to help us celebrate International Women's Day, we've got Baroness Helena Kennedy, who's going to look at what we can learn from successful women's rights campaigns across the globe. So for now, it just remains for me to thank Fred and Gary and to ask you all to give them a round of applause. Thank you.